Hello, listeners. Before we begin today's episode, I want to share an important update with you. The PAOS Las Vegas On-Demand CME package is officially here. We're bringing you on-demand access to all of our 2025 annual conference lectures designed to elevate your orthopedic practice. To start us off, we're giving you a free preview with the November video of the month, Ortho-Oncology, What Not to Miss, presented by Dr. John DeVries. Dr. DeVries' lecture dives into the red flags, referral pathways, and clinical pearls every orthopedic PA should know when encountering potential oncologic cases. It's a must-watch for anyone committed to early detection and optimal patient outcomes. Whether you missed the meeting or want to revisit your favorite talks, PAOS On Demand AV delivers the full experience. Anytime, anywhere. Go to the PAOS.org Learning Center, where you can purchase discounted AV and self-assessment exams to meet your year-end CME needs. Welcome to the orthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice.
My name is Chuck Dowell. I'll be the host of the podcast today. Today we're joined by Tayleigh Talmadge, one of our scholarship winners for the SLMS Scholarship. She did a poster presentation on her project involving medial knee stabilization. Specifically, her project was comparing the medial patellofemoral ligament reconstruction, or MPLFR, and the newest technique involving the medial quadriceps tendon femoral ligament reconstruction, or MQTFLR. Starting with the basics, what is the role that you see regarding the MPFL playing in patella stability? And then what's the difference between the MPFLR and the MQTFLR?
So the MPFL, it has been tried and true. It's been used over the past 30 years in reconstructive surgeries, and the focus is static stabilization. So if you go back to the origins and insertions of these ligaments, it's between the MPFL is between the adductor tubercle and the medial femoral condyle. So we'll use that as like a radiographic landmark called Schodel point, and it'll insert on the superior medial aspect of the patella. So when you do this reconstruction, you get two bony landmarks to use for the graft placement. And people kind of surgeons were really considering, like, would a soft tissue fixation site lead to better outcomes or different outcomes, or how would the patellar lateralization or patellar translation be affected? So the MPFLR really focuses on the static stabilization with those two bony points, and then the MQTFL reconstruction, since the insertion is between the vastus medialis oblique and the distal quadriceps, that soft tissue fixation site focuses more on the biomechanics dynamic patellar stabilization.
Yeah, and we kind of already talked about this a little bit, but if you could just kind of briefly go over advantages and disadvantages to both. You mentioned that the MPFL is more of a static stabilizer, and the concepts behind the MQTFLR is the dynamic stabilization. Are there any other disadvantages to the MQTFLR?
I think for the well-rounded answer, of course, but there's less complications in comparison to the MPFLR. So the MQTFLR reduces the risk of that patellar fracture because you're completely eliminating the bone tunneling into the patella bone. And you also have a reduced risk of distal femoral physis injury because the location of the femoral tunnel is a little bit more proximal to that physis, whereas the MPFL reconstruction really does lie a little closer to that distal femoral physis. So there's that risk. And then there is a reduced risk of abnormal patellofemoral contact pressures when you have the MQTFLR in comparison to the MPFLR. And so overall, there are similar satisfaction, function, and recurrence rates between the two procedures, but I would say the MQTFLR has fewer complications.
Did you research what the overall complication rate with the MPFLR is? I mean, with the patella fractures, and did you research that at all?
Yeah. So the risk that I found is most commonly 3.4%. So pretty slim. but some studies have found it can be as high as 17%. The risk is small, but it's still there. And if you can avoid that, especially if the patient, anatomy, if they have a smaller patella, thinner patella, all of that comes into play.
Do you know what the risk is with the MQ-TFLR?
As far as outcome,
Yeah, generalized risk as far as any associated risk, infections or whatever it may be.
not terribly. I would say they're pretty similar. There is a risk of like the non-anatomic fixation, or if you have soft tissue gaps in the graft placement through the soft tissue. And then you have to think about that small chance of the defect in the quad and ACL reconstruction in the future if you want to use that.
But no document, although it hasn't been done for a while, risk of increased quadriceps tendon rupture that we know of, but
No.
didn't see that in the documentation.
No, I didn't.
And then just for my clarification, I think I heard you correctly, but I'm just curious about this. You said the contact pressures, there's a difference. Is that the
Yeah.
MPFLR has increased contact pressure compared to the MQ-TFLR?
Yeah, that some studies did find that, and it's with the graft tensioning. There's a risk of overtensioning with both of these procedures, and so surgeons have found that the 2 newtons of application of force is sufficient to align those two anatomic levels, but 10 newtons of tension I found was enough to even alter those a little bit and not result in comfortable recovery for the patient.
Yeah, it's interesting. That's an interesting because I've done a handful or help with a handful of NPFLRs, and there's definitely a constant concept of am I over tensioning this and over tightening this or not? And that makes sense. If I over tighten it, then I increase the contact pressures, which increases the load on the chondral surfaces, which potentially causes damage in the future. When we do an NPFLR, we're able to kind of find that concentric point and move that distal attachment point to get that concentric point, actively during the surgery. But because the MQ-TFLR is a dynamic structure, are they able to do that in the OR? Do you know? Or is it just we try to put in that appropriate position? Because you can't get quad activation when the patient's asleep.
Right, and I think that's why they focus on the graft tensioning at 30 degrees of knee flexion when they do the MQ-TFLR, and so, I'm not even sure how you guys measure the amount of tension that you get on the graft, but they do, keep that in mind. I don't think it's just based on, the naked eye.
Yeah, I haven't assisted in one of these yet, so I'd be curious to assist. I know with the MPFLR reconstruction, we fixate it proximally, and then we kind of use a pin to mark a position, what we think is that concentric position distally on the femur, and then we flex and extend the knee, and we kind of move that pin until we get a concentric position. But because everybody's anatomy is a little bit different, we have to kind of not be directly in the anatomical landmarks. We try to get as close as possible and take an x-ray, but again, anatomy differs. And so I'd be interested to assist in one of these and kind of see how that process goes.
Yeah, and that's how I saw it done, was my too, yeah.
I think one of the interesting concepts to this, and a lot of these patella instabilities are in younger patients, and seeing these patients definitively have open growth plates and probably more of a female dominant population than a male dominant population. So having to be able to, or the preservation of the growth plate and having that more proximal femoral attachment is definitely an advantage. Did you assist or see any of these in open growth plate patients?
I did not, unfortunately. I think that would have been a really valuable opportunity, but our patients were typically 18, 19.
Yeah, yeah. But I mean, with any of the pediatric sports stuff, the more you can preserve that growth plate, the better. And so having these alternative, treatment options to preserve that growth plate definitely helps in that population for sure. And then we talked about this briefly. You had said when we look at the clinical data, or when you saw these patients back in clinic, did you see patients back that had the MPFLR compared to the MQ2? Well, I just can't pronounce that today. MQTFLR? And like, how would you compare them as far as post-operatively seeing them?
So I actually saw 2 revisions of the MPFLR with the MQ-TFLR, and then I saw 2 that were just straight MQ-TFLRs. I don't really have a good take on how the isolated MPFLR went in comparison to the other. But my physician really does prefer the MQTFLR because of the ability to strengthen that quad and make the graft that much more taut.
But you mentioned post-operatively an advantage is they can weight bear taller to correct. They're not using assistive devices. They're not using a brace. What else did you see as far as quicker recovery?
Physical therapy went faster, I would say, for the patients. And not using that brace or having to weight bear with crutches or a cane or anything like that. That was a big advantage. They were fully weight bearing like within 1 to 2 weeks. And then their overall recovery, they did have a faster return to sport in comparison to the MPFLR. So they averaged like 4 months to get back, whereas I think I read the MPFLR was like 4 to 8.
Yeah. Yeah, that's interesting. That's very interesting. And sometimes if we over tighten that MPFLR, flexion's hard to get back afterwards. And so it's nice. They probably were able to get the range of motion back a lot quicker and start working on the quad activation a lot quicker, which, as we had previously discussed, can be an issue sometimes with these surgeries. So
Right.
definitely interesting. Well, as I said, I think you did a great job with the paper and the poster presentation. We appreciate you coming on the podcast. We always finish it with anything we've missed, anything else that we haven't discussed and you wish we had covered, or?
I think we touched base on a lot of these, but I am interested to see if maybe using a different graft comes into play, since we do rely so much on the hamstring. And so I know that in the research, the hamstring is obviously going to be so different than anatomical, natural ligament. So I'm wondering if one day we'll move into something else, whether that be an allograft or a different autograft or something artificial. Who knows?
Yeah, that makes
But
sense. For clarification, when you guys did these, you used hamstring autograft, semitendinosus? Yeah, okay.
Yep.
Yeah. I know some will use that and some will use hamstring allograft, for them. So, but all of yours were hamstring autograft.
Yes. Yeah.
Yeah. And then there's as you said, the concepts regarding, possible hamstring issues afterwards and the healing from that too. So definitely interesting as it progresses to see, how the concept of this progress. Join us next week when we talk more with Tayleigh regarding her poster presentation on medial patellofemoral reconstruction and different concepts regarding graft techniques. Also, don't forget to check out the CME on demand from the PAOS website from our most recent conference in Las Vegas, where you can have access to all the videos and presentations and earn your CME that way.
Thank you for joining the orthoPAC podcast. We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.